filled academic session to our State President's Action Plan PG Teacher Program 2023. I welcome everyone, respected Joe Sir, State President IAP Kerala, our faculty for the day, Dr. Shankar VH, Vice President-elect, faculty Dr. Roy Sankar Sir. Sir is Professor and Head of the Department of SUT Medical College. Mentor for the day, Dr. Swapna S. Pillai. Madam is Associate Professor of Gogula Medical College. And Dr. Shanama Sir, State Coordinator, PG Teaching Program. Dr. Kalpana Madam, Coordinator, PG Teaching Program, Trivandrum. Our IAP Trivandrum President, Dr. Rukmani K. And all the senior faculties, our beloved Lalita Kailas Madam, our respected Shushma Bai Madam, and all the senior senior faculties and all the pediatricians. Welcome you all to our PG teaching program. And now I would like to hand over the mic to our State President, Dr. Joe Sir, to deliver the presidential address. Over to Joe Sir.
Thank you, Dr. Benno. The President of IAP Trivandrum Branch, Dr. Rukmani, Madam, and Senior Faculties of IAP Kerala, Dr. Sushma Madam, Lalita Kailas Madam, Purushottam Sir. Today, the leading faculty, Dr. Shankar, the Vice President of IAP Kerala and Professor of Pediatrics, SAT Trivandrum. Professor and HOD, SUT, Dr. Roy Sankar Sir. And Dr. Swapna Pillai Madam from Sri Gogula Medical College. And today, the presenter from Sri Gogula Medical College, PGs, and all the PGs of Sri Gogula Medical College, and all the PGs are joined here. We are again assembled here to another important activities of IAP Kerala, the PG teaching program of clinical case discussion. As everybody know, this is we are conducting regularly every Thursday at 7:30 p.m. As you know, it is very useful for the PGs concerned. They had to be discussed the approach of different case scenario by different faculties from and the field of process from different medical colleges. Today, none other than our Professor Dr. Shankar is here to discuss yet another topic of today's program, adolescent with a chronic anemia. And the program of the PTCAM is coordinated by none other than our Professor Dr. Shanava Sir, and the Trivandrum branch coordinator Dr. Kalpana, and Secretary Dr. Benno, and Rosemary, and President Rukmani Madam is arranged in a wonderful manner. I think this program is very useful for all the PG students. I want to announce some of the important action plan this month. Next Friday, the IAP Kerala is going to arrange a summer pedicon hosted by IAP Presentor branch in an excellent manner. At the program is will start from 9 a.m. to 4 p.m. at KTA Elite Hotel, Tiruvalla. And the 12th and 30th of this month, it's another important program of the Kerala State Neocon Conference arranged by IAP Thrissur and NNF Kerala. Along with the Neocon, IAP Kerala is one important action plan is going to start mid-zone TOT of comprehensive newborn care for the general practitioners concerned. I request those who are interested can be participate that program. That is without any registration fee. We are planning to conduct another important action plan. All the aspect of the newborn care by the general practitioner at the peripheral level. I think that is one of the important programs arranged by none other than our Nihas from IAP Kozhikode. He is arranging the state convener for the program. Anybody want to participate in that program, please contact either Nihas or me or any NNF President Secretary of Kerala. So very, very happy to include those who are interested for this program. And I think I request everybody to utilize this program. Again, another important that all the PG tips and the PG clinical programs are uploaded on our website. I request all the PGs and all the practitioners to visit our website and utilize this golden opportunity for the PG students for their academic events concerned. With these words, I open this program for today program is inaugurated. I wish you all the best. Jai Hind, Jai IAP.
May I call upon Lalita Kailas Madam to speak a few words? Madam? Lalita Kailas Madam, one second.
No, Beno, I think you should not waste time on so many felicitations. I think you can go directly. I wish all the best for the program, right?
Thank you, Madam. Thank you. So, thank you, Lalita Kailas Madam. Thank you, Joe, sir. Now, we shall go for, we'll proceed with the presentation.
Okay.
Okay. Swapna Madam, can we start off with the presentation?
Yes, sir, we can start off with the presentation. Sayana, can you please start?
Yes. Can I share the screen, sir?
Yes, yes.
Shankar sir, anything want to say before?
I think since it is an online program, we will in between, we are not going to break. Sayana, you can present the history. In between, if there is not much to add or discuss, we will not discuss. After the history, we will take the discussions. Roy Sankar sir, anything to tell? Roy Sankar sir?
Unmute. Yes, it can continue. It can continue. No problem.
അപ്പോൾ അതുകൊണ്ട് ഇടയ്ക്കിടയ്ക്ക് നമ്മൾ ബ്രേക്ക് ചെയ്യണ്ട എന്നാണ് എനിക്ക് തോന്നുന്നത് ബിക്കോസ് സമയം ഒരുപാട് പോകും ഹിസ്റ്ററി ഒന്ന് പ്രസന്റ് ചെയ്തിട്ട് വി വിൽ ഡിസ്കസ് മുഴുവൻ വേണ്ട ഹിസ്റ്ററി മാത്രം എക്സാമിനേഷൻ വി വിൽ ഗോ ലേറ്റർ ഓക്കെ
Good evening, sir.
Sayana, you can start.
Good evening, all. I am Dr. Sayana Kumar, Junior Resident, Sri Gurula Medical College. Am I audible, sir?
Yes.
Audible.
Presenting the case of Vinita, 17-year-old girl, hailing from Alamgod. Date of examination is 27/4/2023. Informant is mother and is reliable. She is a known case of hematological disorder, came for blood transfusion. As the symptoms started from the infancy period, I would like to start the history from the infancy. Baby was thriving well till 6 months of age, according to the mother. At the age of 6 months, she had a febrile illness for which she consulted a local hospital, detected to have severe pallor. From there, she was referred to the SCT hospital. At that time, she had no jaundice, no history of any bleeding manifestation. Child was evaluated at the hospital and the parents was counseled that she had some hematological disorder and will require regular blood transfusion. And from there, child was started on daily oral medications. As they were counseled about regular, but even though they were counseled about the importance of regular blood transfusion, they couldn't adhere to it. Parents and the elder siblings were advised testing for the similar illness, but only done for the elder sibling as the parents were not willing for the same. Child had progressive dyspnea and decreased activity in between, and they were taking irregular transfusions. Child also had pervasive abdominal pain, causing severe discomfort to the child, along with worsening of the pallor. At the age of 5, abdominal surgery was done and was started on regular oral post-surgery medications. Child was hospitalized twice at the age of 6 and 8 years with worsening pallor, dyspnea, and easy fatigability, and was given blood transfusion at these admissions. During one ICU admission, investigations revealed high blood iron content and started on some oral medications by the age of 8 years. On going to detailed history, we got that the child used to get some IV medications each time when the child came for blood transfusion by the age of 3 years of age. Mother also noticed that the child was shorter than her peers, also has not attained menarche and any breast development. Child is still getting blood transfusion and on a regular basis, and daily oral medications is also being continued. There was no history of jaundice any time during the illness. There was no history suggestive of hypothyroidism. There is no history of polyuria, polyphagia, and weight loss. There is no history of any skeletal abnormalities. Coming to the birth history, child is the second-born child of non-consanguineous marriage. Antenatal period was uneventful. There was no history of any maternal anemia or blood transfusions. Child was a term, well, it was a term vaginal delivery 3.5 kg right soon after birth. Neonatal period was uneventful. There was no history of jaundice. Mother and baby was discharged by postnatal day 3. Immunization. Child was fully immunized for age before abdominal surgery. Some vaccines was taken, but the details of the vaccines are not known. Last doses of the last vaccination was taken at 16 years, which is TB. No history of any adverse reaction following immunization. History, there is no delay in motor and social milestone. Because of the chronic illness and the recurrent hospital admission, child had school absentees and passed 10th with the help of scribe. Dietary history. Child is taking a mixed diet. Observed calories is 1,330 for the 1,900 calories expected. Protein is 55 for the protein is 27 for the 55 calories expected. There is a deficit of protein of 30% and a calorie of 28%. Child is on calcium and vitamin D supplements. Family history. Child is a second-born child of non-consanguineous marriage. There is no history of hematological disorder in the family, no history of any blood transfusion or abdominal surgery in any of the family members. Socioeconomic status. Mother and father studied till 10th. Father is a mason and mother works as a housemaid. Lives in a Pakka house. They are 4-membered family. Belongs to the upper lower class family according to the modified Kukusami scale 2022. They are beneficiary of Talolam scheme. Coming to the summary, this is a 17-year-old girl with history of significant anemia from 6 months of age, requiring repeated blood transfusions but on irregular follow-up. And there was no history, history of jaundice any time during the illness. An abdominal surgery was done at the age of 5 years. Child is on some oral medication and the child is shorter than her peers.
Okay. And I think, am I audible?
Yes, sir.
Okay. Only one clarification. You told regular blood transfusion. Okay. So just I want to know how frequently, because that is important in this case. That is from when it started on 6 months, how frequently it was. Later it is increased or not. Later it has changed or not. These things are very, very important. So some more light on that, how frequent it is.
Initially, they was advised to take transfusions once, twice a week, one transfusion, 2 to 3 weeks, one transfusion was advised to take, but they took irregular transfusion, like mostly monthly once or 1.5 months, only one transfusion was taken.
So they were not taken transfusion as per advice. Okay. So once in 6 weeks or something only they are taking transfusions, regularly transfused. Okay. So, what do you feel from seeing the history? What is it in your mind? What are the possibilities? Because you told it is a chronic anemia detected at the 6 months of age on regular blood transfusion with no history of jaundice and with some growth retardation and some abdominal surgery at 5 years of age. So what are the possibilities you think?
With this history, it is a congenital hemolytic anemia.
So what is the point? What is the point against congenital hemolytic anemia? So what is the triad of hemolytic anemia?
Hemolytic anemia, jaundice, hepatosplenomegaly, splenum, jaundice.
Pallor. Okay. So pallor and hepatosplenomegaly you cannot get into history, but here you told there specifically there is no history of jaundice at any time. Still you want to consider chronic hemolytic anemia. Why? Because you specifically told no history of jaundice at any time, but still you are considering first possibility as chronic hemolytic anemia. Why?
Because in this case, there is the peripheral hemolysis is less, intramedullary hemolysis is more. So we can
Intramedullary means intravascular, intramedullary. Okay. That intramedullary hemolysis will not cause jaundice.
It can cause jaundice, but it will be mild compared to the anemia.
Okay. So you feel because of the intramedullary hemolysis, there is no jaundice. Okay. Then tell me. So this one is chronic hemolytic anemia, but jaundice is one thing which is, but I will explain later why that is right or why it is wrong. We will come to that later. Then any other diagnosis you want to consider? Apart from chronic hemolytic anemia, which hemolytic anemia we will come later. Okay, one group is chronic hemolytic anemia, which require transfusion. Any other conditions where there is a regular transfusion may be required?
Group of conditions would be congenital bone marrow failure syndromes.
Congenital bone marrow failure syndrome. Is it possible in this child?
Unlikely.
So which congenital bone marrow failure syndrome can present with a 17-year-old with only blood elements, RBC elements are destroyed?
Pure cell dysplasia.
Pure red cell aplasia. Okay. PRCA, pure red cell aplasia. Okay. So PRCA can present, but there are so many odd points are there, which we will discuss. So one thing is the bone marrow failure syndrome. Then, so you told no neonatal jaundice. Why you are very strongly tell no neonatal jaundice?
There is no history of any hereditary spherocytosis or other enzyme for this.
So hereditary spherocytosis can present with a neonatal jaundice. That's the thing you want to tell.
Yes.
So if there is no neonatal jaundice, it cannot be hereditary spherocytosis?
No, sir. It can present at any period of time.
Any period of time. Okay. But classically or one of the presentation of hereditary spherocytosis is the neonatal jaundice. So what are the presentation of hereditary spherocytosis?
It can present with jaundice at the neonatal period.
Okay, good. Then
Presented, detected accidentally during the child can be asymptomatic and detected accidentally.
Okay.
Can present with recurrent jaundice, hemolysis, and hepatosplenomegaly also. Severe forms requiring blood transfusions.
Correct. Then fourth presentation.
Crisis.
Asymptomatic splenomegaly. Asymptomatic splenomegaly. Somebody has written gallstones. That's correct, but gallstones also you have to do. So it can be gallstones. It can be asymptomatic splenomegaly. So without much hemolysis and requiring blood transfusion, it can present as a asymptomatic splenomegaly. Because if an adult 16-year-old or 8-year, 10-year, 15 years, asymptomatic, isolated splenomegaly, one of the differential diagnoses you have to consider is the hereditary spherocytosis. So one of the hereditary spherocytosis presentation can be like this also. 6 months it has been started, severe form, there can be regular transfusion. So what is the point against hereditary spherocytosis? There is no jaundice. That is a major thing we cannot say, because hereditary spherocytosis, whenever there is significant anemia, which is requiring transfusion, there should be some jaundice should be there. Okay. Then one more thing I will ask, then I will switch over to Roy Sankar sir. So you told family history is nothing contributory. So what are the points you want to consider, situations you will consider why family history is important in this case?
Family history of in case of autosomal recessive conditions and dominant conditions, we will get a strong family history. X-linked also we can.
I have asked in this case, what is the importance of family history? So you are considering a chronic hemolytic anemia or congenital bone marrow failure syndrome. These are the most two important conditions you are considering. So considering these two group of condition, what is the importance of family history? That is a question. That is the autosomal recessive, autosomal dominant, X-linked. These things are okay.
Anemia, spleen, abdominal surgeries, any hematological disorders, diagnosed hematological disorders in the family, all these are important.
So what is the cause of chronic hemolytic anemia? Genetic causes. Your answer should be, if somebody asked you like this a question is very important or common or most important cause for a chronic hemolytic anemia is genetic causes. So since it's a genetic cause, there is a chance of inheritance or family history will be present. Then only you have to go to autosomal recessive. So what are the autosomal recessive conditions in this group? Chronic hemolytic anemia.
Thalassemia, sickle cell anemia.
Correct.
Then
What about hereditary spherocytosis?
Dominant in hereditary spherocytosis, X-linked recessive in G6PD.
Okay, hereditary spherocytosis can be autosomal recessive as well as autosomal dominant. 75% cases of autosomal, that is 75% is not absolute. It is for teaching purpose we will use 3/4 or 70, almost 3/4 of the cases will be autosomal dominant, which is a milder forms, whereas some of the things are autosomal recessive also. Because hereditary spherocytosis is not like thalassemia. Thalassemia is always due to a same gene defect, always due to beta globin mutation defect. Whereas hereditary spherocytosis is a clinical spectrum of conditions which can be due to 4 genes, which is important for the membrane cytoskeleton. Which are the 4 genes?
Ankyrin, spectrin.
Very good. Ankyrin, spectrin, band 3.7 and band 4.2. So each gene have different types of inheritance. That I don't think you have to know, but you should know that there are 2 types of presentation. It can be autosomal dominant, in which situation most probably it will be milder forms, just like I told you, once in a while transfusions or asymptomatic splenomegaly, etc. will be there. Whereas in autosomal recessive form, most of the time it will be a severe form where child may be transfusion dependent, just like a thalassemia major. So they are dominant and recessive, both are important. And what about pyruvate kinase?
X-linked recessive.
Pyruvate kinase is autosomal recessive. Only G6PD deficiency is X-linked recessive. Pyruvate kinase is autosomal recessive. And some of the other non-spherocytic hemolytic anemias are there, like stomatocytosis, elliptocytosis. These are all autosomal dominant conditions. So there are autosomal dominant chronic hemolytic anemias, recessive hemolytic anemias, X-linked hemolytic anemias. Similarly, if you come to the bone marrow failure syndrome also, if you divide the acquired aplastic anemia, conditions like this case, from even if it cannot be acquired aplastic anemia, very unlikely. It may be, but very unlikely. So you have to consider a congenital bone marrow failure syndrome also. There also it can be autosomal dominant or autosomal recessive or X-linked. Various conditions are there, which I'm not going to that detail. But generally, as you told, Diamond-Blackfan syndrome is there. Fanconi anemia, in this age group, we cannot consider, because usually by this age, other presentations also should be there. Somebody has told Diamond-Blackfan has to be considered. But Fanconi anemia also, even though all cell lines has to be reduced, every cell lines may not come together at a time. It is an evolving thing. First, only thrombocytopenia will be there. After 3-4 years, leukopenia will develop. After 3-4 years, there will be hemoglobin will be reduced. So it is an ongoing process. But 17 years, abdominal surgery is a little bit difficult to accept. It's not directly linked. It means something else. But abdominal surgery on Fanconi, you told short stature also is there. So Fanconi also you have to consider in a chronic anemia requiring blood transfusion. 6 months present. Yeah. Other factors, history we have not investigated. So a bone marrow failure syndrome, Fanconi is autosomal recessive, most of the Fanconi. So this type you should answer, because so many diagnosis or 80% case genetic related conditions, which can be recessive, dominant or X-linked, which require a detailed family pedigree is required. Okay, these are the two things I want to discuss. Rest of the thing, any question is there, I will answer. Roy Sankar, sir, anything?
Yes. Yes, good evening. Actually, I'm happy that she has answered all the types of inheritance. Nowadays, undergraduate students, actually, they never know, they don't know what is this autosomal dominant, autosomal recessive, X-linked recessive and all. Here, hemolytic anemias, all the types of inheritance are there. And not only that, in hereditary spherocytosis, both can occur. And another one more presentation of this hereditary spherocytosis is at times the child is diagnosed as hereditary spherocytosis, and when we palpate the spleen of the mother, she will be diagnosed as hereditary spherocytosis. Rarely that can be fully asymptomatic also. So we have come across cases like that. So being an autosomal dominant condition, the only small affection will be there and can get unnoticed, and they can go into the adulthood, maybe 30 years or more, asymptomatic. But they may be having some symptoms like mild jaundice and other features, anemia and all, but might not have been undetected. Such cases also have been reported in the city hospital previously. Okay.
Anybody wants to ask something, or I will discuss some more things, then we will go to examination. Anybody wants to ask anything? Or comments or suggestions or any more questions you have to ask Rania, because as a general thing, for a short case, because most probably this case will be given as a short case only, not given as a long case. For a short case, this is reasonably, I don't think it is, diagnosis is staring. Diagnosis is not a very big issue in this condition. Diagnosis is staring at us, but you can ask a lot of things again, because for example, some of the complication you told, child has not attained menarche, child has not attained shorter than peers, but so many other things also you have not given in the history. You can give, but it is not mandatory because it's a short case. During examination also you can tell. So other complications of chronic hemolytic anemia on blood transfusion, it is we can give us so many things can be added, but I think that can be discussed during the examination also. Anybody wants to ask something, students? ആർക്കെങ്കിലും എന്തെങ്കിലും സംശയമോ ഡൗട്ടോ രണ്ടും ഡിസ്കഷൻ പോയിന്റ് ആണെങ്കിൽ ശരി, or clarification from the presenter, രണ്ടും can be asked. Then we will go to examination. Nothing is there. Okay, so from the history we know that it is a 17-year-old girl with a chronic anemia, onset at 6 months, requiring blood transfusion, some abdominal surgery and medication, and shorter than PS already she told. So probably we are dealing with a chronic hemolytic anemia. So any other, what are the other anemias you will consider? Correct. That's the thing I want to ask. Shija has asked that question. So what are the other possibilities? These are the main important possibilities. So what are the other possibilities? So got to a broader sense, what are the other possibilities? Sayana. What are the other possibilities we will think? Sayana or Nasia. Nasia can tell. Nasia, unmute yourself and tell me what are the other possibilities.
No, sir.
Nasia, tell please.
Sir, any chronic blood loss causing anemia?
Okay. Example?
Like cow's milk protein allergy or Meckel's diverticulum.
Okay, infection like that, but somebody has got parasitic infection. But there are some odd points are there, because regularly requiring transfusion, all those things are not very classical of that situation. Regular transfusions and other things cannot be explained, but definitely you have to consider some condition with the chronic blood loss, or a chronic condition with the malabsorption and blood loss with anemia and short stature, adolescent girl. Any other condition? Can it be celiac disease?
Celiac disease.
Somebody has told celiac disease. Celiac disease. So in any adolescent girl presented with such a chronic history, always one of the differential diagnoses is celiac disease. I have not seen in my 15 or 20 years of practice in Trivandrum, but during my DM period in SGPGI, where celiac disease is more common, I'm still remembering 2 cases. Same adolescent, 15 to 18 years old girls came to the genetic department for evaluation of thalassemia or some genetic anemia. Finally turned up to be celiac disease. But only thing is, this much regular blood transfusion is very unlikely. That's what I told. Here it is clear cut. Your history itself showing only one diagnosis is possible. But generally, in between transfusion, once in 3 months, once in 4 months, chronic anemia, significant short stature. So celiac disease is one important consider. You have to consider celiac disease. Cow's milk protein intolerance, definitely there should be. Itra age 6 masam to continuous without any severe failure to thrive, diarrhea, all those things are not that much likely. But celiac disease can present like this. You can do the literature also. They will always say any chronic anemia, rule out celiac disease. Okay. Any other? Regular blood transfusion on the Mati Vechal, our typical presentation Mati Vechal, 17-year-old with anemia, chronic anemia. What are the other possibilities? One is chronic blood loss. Somebody has told CKD. Very good. Can it be chronic kidney disease? Sayana, can it be chronic kidney disease?
It could be, but
because short stature, it can be there. You told abdominal surgery done at 5 years. Abdominal surgery can be due to some kidney problem, some nephrectomy. You have not told anything. It may be some nephrectomy. There also only problem is this 6 months. Why this 6 months? You have told 6 months, 6 months, 6 months. Why 6 months is important?
It is a time when the fetal hemoglobin reduces and the adult hemoglobin take over.
So which condition will present at 6 months?
Thalassemia can present at 6 months.
Thalassemia major. You have to tell the diagnosis completely. It is thalassemia major. Why thalassemia major is presenting at 6 months or opposite only at 6 months, not at birth?
At birth, we are having hemoglobin F, which consists of alpha 2 and gamma 2.
Correct.
About 4 to 6 months for the gamma 2 to go and the beta hemoglobin to come.
So when there is beta thalassemia, question, answer. When there is beta thalassemia, there is defect in producing beta globin only. Beta globin, hemoglobin A ki matrame ullu. Hemoglobin A is alpha 2 and beta 2. So hemoglobin A is not formed. So in normal individuals also, majority of the hemoglobin is by hemoglobin F at birth, which is gradually replaces by the hemoglobin A. This replacement will occur gradually, and by around 6 months, hemoglobin A will take over most of the function. So when there is a mutation in the beta globin chain, beta globin is not formed, hemoglobin A is not forming, so anemia will set in by around 4 to 6 months only. So anemia at birth, never ever diagnose thalassemia, beta thalassemia major. That is disastrous. Never it will present. Anemia in the newborn period or 1 month or 2 months, beta thalassemia major or DD ആയിട്ട് പറയാനേ പാടില്ല. It will not present. Alpha thalassemia can present, but it is a totally different perspective, which is very unlikely to be present in the Indian subcontinent. So beta thalassemia major എന്ന് പറഞ്ഞാൽ 6 മാസം ആവണം. So repeatedly you are telling it is 6 months, 6 months, 6 months. So അതാണ് ഞാൻ പറഞ്ഞത്, ഇതിലെ ഒരു diagnosis is ഇങ്ങനെ അടിച്ചു വെച്ചിരിക്കുകയാണ്. It is direct diagnosis. But still, a patient with a chronic anemia, always you have to think a CKD. So you have to tell കുറച്ചുകൂടെ ഒരു broader sense ൽ CKD-യുടെ evidence ഒന്നുമില്ല. ഒന്ന് ഒരു celiac disease, chronic malabsorption, chronic blood loss. അതെല്ലാം ഒരു ഗ്രൂപ്പായിട്ട് എടുത്താൽ മതി, because അതിലൊന്നും സാധ്യത കുറവാണ്. Then CKD always you have to consider where there is a anemia പ്രശ്നങ്ങളോ എന്തെങ്കിലും ഉണ്ടോ എന്നുള്ളതോടെ very important ആണ്. So somebody has told Fanconi Curie. That already we have discussed. Second, two most important causes are chronic hemolytic anemia and bone marrow failure syndrome, followed by a chronic kidney disease, celiac disease. Then, can it be a nutritional anemia?
Could be iron deficiency anemia.
But there again, still, same problem is there. Why it is not responding regularly, requiring transfusions. All those things are a little bit difficult to explain. But some chronic iron deficiency anemia or any other thing adolescent or because since I have not seen somebody has IRIDA is possible, but IRIDA still is not a very common condition, number one. Number two, it will not requiring regular blood transfusion, like every 3 weeks, 2 weeks. So it is not classically fitting. So some iron deficiency which is not responding can be a possibility you can consider for just an enumeration case. Similarly, can it be megaloblastic anemia? Because since adolescent you told, because I don't know when you are presenting, before that I don't know the case. So I thought it may be a case I thought megaloblastic anemia, always you have to consider in adolescent girl. But here also it is 6 months onwards, they are very unlikely. So megaloblastic anemia is not fitting into history itself, you can almost ruled out. Because 6 months any type of megaloblastic anemia. Megaloblastic anemia can be due to some congenital inborn errors of metabolism controller, in IAP controller deficiency, folate deficiency, in whatever it may be. I'm not going to the details. There are some genetic conditions or metabolic conditions which can present with the anemia, which is requiring transfusion. But there we are expecting much more severe developmental delay. Those things are we are expecting. And they will to presentation and broader sense because they the case I present transfusion case the case CKD and these things you have to consider. And during history, always you have to add those type of points. There is no chronic kidney disease and symptoms urinary symptoms because those things also you have to consider. Any other thing? Okay, with this, I think we will go to the examination.
Starting with the general examination, child was conscious and oriented, appears shocked for age. There was severe pallor, no jaundice, heart rate was 104 per minute, rhythm was regular, high volume and normal character, no radioradal or radiofemoral delay, respiratory rate was 26 per minute. BP was 110/70 millimeter of Hg in the right upper arm in supine position. Saturation was 98% in room air, and there was no generalized lymphadenopathy and edema.
Okay, go ahead. So only severe pallor is there.
Head to foot examination, child had hemolytic phases. There was generalized hyperpigmentation. Severe pallor was present. There was no jaundice. Oral cavity, the oral mucosa appeared pale. There was dental caries. Dental malocclusion was also present. Neck, there was no thyroid swellings. Abdomen, it was distended. Horizontal scar of 10 centimeter was present in the left hypochondrium. Pubertal assessment and stage 1 breast and pubic hair.
Tanya, can you explain what is hemolytic phase?
Hemolytic phases, there will be frontal and parietal bossing, broad flat nasal bridge, prominence of the maxillary prominence will be there, malocclusion of teeth will be there.
So what are the situations that we have already discussed where hemolytic phases can occur?
It is seen in chronic hemolytic conditions like thalassemia. It can be seen in hereditary xerocytosis and chronic hemolytic conditions.
Okay. Can it be seen in iron deficiency?
It can be seen if it is a chronic condition, we can see.
Correct. Even in chronic iron deficiency, there can be in a milder form. It may be in the milder form. What is the reason for this hemolytic phases?
It is due to the ineffective erythropoiesis that is which is happening in the bone marrow, medulla of the bone marrow.
Will be diploid space will be widened. It will be extramedullary hematopoiesis. There will be widening will be there. So it was generalized hyperpigmentation. And why you have not put it red? Because I think that is very important finding, generalized hyperpigmentation. So what are the situation among we discussed? What are the situations where you can consider generalized hyperpigmentation?
In Fanconi's anemia, we can see hyperpigmentations can be there.
Correct.
It can be seen in megaloblastic anemia. In
But
tyrosine,
megaloblastic anemia, pigmentation will be basically seen in the
knuckle pigmentation.
more seen in the clearly seen in the knuckles. Generalized hyperpigmentation are very common. One is Fanconi's anemia. There can be definitely hyperpigmentation there. So can it be Fanconi's anemia?
Unlikely. First presentation is more of thrombocytopenia is the most common.
That is perfectly correct. Usually it will present as thrombocytopenia. Later only it will extend into. So presenting at 6 months with anemia requiring blood transfusion for 17 years, there is no other features is very unlikely. And what are the other features of Fanconi anemia you will expect in general examination?
It will be short.
Short. This patient is already short. What are the other features you will expect?
Facial features like microcornea can be there. Skeletal abnormalities will be there. Thumb
What type of skeletal abnormalities?
Triphalangeal thumb.
Extremities. What type of extremities abnormalities?
Bifid or triphalangeal thumb.
Okay. Okay. So it can be a triphalangeal thumb. It can be aplasia of the thumb. Okay. There can be radial defect. All those things are possible. Some skeletal abnormalities we have to think. Then microcephaly. Head circumference will be low. Microcephaly will be usually associated. Short stature will be there. That already you told. Okay. Then eyes you told severe pallor and no jaundice. That already you have told. And oral mucosa appears pale. Any other abnormality? Because any other group of condition we told you have to see in oral abnormalities, any pigmentary abnormalities or thing?
There was no pigmentations in the oral cavities.
No pigmentations was there. Pigmentary abnormalities you can see in Fanconi. Any bone marrow failure syndrome, it can be pigmentary abnormalities. You can see. Classically, condition bone marrow, but this cannot be fit into this. Bone marrow failure syndrome, classical oral pigmentation condition, especially in 17 years. Definitely it will be there. Correct. Diskeratosis congenita, somebody has told. But it is not, presentation is absolutely not diskeratosis congenita. I'm not telling it is diskeratosis congenita. Just for the terminology I have discussed, that's all. Because diskeratosis congenita, anemia and leukopenia, etc. will come only in the adolescent and post-adolescent period. But the early presentation of diskeratosis congenita is the oral hyperpigmentation. So pigmentation in a chronic anemia is very important, but not in this case because it is. And pigmentation can be there due to this generalized hyperpigmentation in chronic hemolytic anemia is due to
increased
iron overload. Increased transfusion related iron overload, which can also produce hyperpigmentation. Severe overload undengil mucosal hyperpigmentation varam. Okay. That was specific item. You can say there is no hyperpigmentation in the mucosal area. It's very important. And you have to specifically say that there is no palatal spot, palatal bleeds. Because in chronic anemia, I told you, most important thing is I want to know whether it is leukopenia and thrombocytopenia. And most of the time, it is an investigation-based condition. That is why this we are keeping only as a short case. Because for the examination, you cannot give any, even differential diagnosis are very difficult. It's a broad only. Only major thing is the blood investigations is very important. But clinically, we get few signs and any signs of thrombocytopenia, like any palatal bleeds, any skin bleeds, those things. No thyroid swelling. Okay. Dental malocclusion is there. Okay. Then pubertal abdomen distended. Okay. Roy Sankar sir, in general examination, anything to add? Sir?
No.
Okay.
Nothing.
Anthropometry, a child had a weight of 34 kg, which was less than 3rd centile. Height of 137, that was also less than 3rd centile. BMI was 18, between 10th and 25th centile, and mid-parental height was 155, between 25th and the 50th centile.
So when height is less than 3rd centile, whenever there is shortness, we want to know the severity of the shortness. That's routine discuss. You will just say less than 3rd centile. But that is not enough. Because when child is in the 7th centile, child is in the 6th centile, or child is in the 4th centile, as far as Sayana one impression. But as far as we are considered, when we are considering DD for growth retardation, the severity of shortening is very, very important. Everybody is understood. If less than third centile means it can be very severe. But it will be less than third centile only. So ideally, when you are analyzing a growth retardation, it is better to tell how far it is below the third centile. How many SD below? I think 2 SD, 3 SD, 4 SD, 5 SD. Because when you are discussing a short stature case, shortness is very important. How severe is the shortness? Shortness case, we will divide the differential diagnosis into minus 3 SD to minus 5 SD, minus 5 SD to minus 7 SD, or condition with less than 7 SD. Severe short. At least we should know what is the severity. So what is the height age of the child? Height age of the child. Retrospective angle. What is the height age? Height age?
Will be about 7 years.
7 years. How 7 years? Expected is 137, you told. What is the present height?
Present height is 137.
Present height is 137. You told expected.
10 years. Will be about 10 years.
10 year. Correct. It is 10 year. Because 137 is your height. But they are heading that expected.
Right.
Actual observed.
Yes, sir.
137 centimeter എന്ന് പറയുമ്പോൾ നമുക്ക് നിങ്ങൾ എഴുതി കൂട്ടിയൊക്കെ നോക്കി ഞാൻ കാണുന്നുണ്ടായിരുന്നു 137 മൈനസ് 6x + 77 എന്നൊക്കെ കൂട്ടി നോക്കി അല്ലേ 10 വയസ്സ് കിട്ടാൻ സോ അതിന്റെ ആവശ്യമില്ല ഇറ്റ് ഈസ് വെരി വെരി ഈസി ഹൈറ്റ് 4 years 100 centimeter after that every age 6 centimeters 4 years 100 centimeter above that അപ്പോൾ ഓട്ടോമാറ്റിക് ആയിട്ട് 137 കേൾക്കുമ്പോൾ തന്നെ 137 മൈനസ് 100 37 ഡിവൈഡഡ് ബൈ 6 6 36 6 4 10 വയസ്സ് സോ 137 എന്ന് പറയുമ്പോൾ തന്നെ വി ക്യാൻ നോ ദാറ്റ് ഇറ്റ് ഈസ് 10 year ഇസ് ദി ഹൈറ്റ് പറഞ്ഞു മനസ്സിലായോ നമ്മൾ അണ്ടർ ഗ്രാജുവേറ്റ് 6x + 77 ഒന്നും കൂട്ടണ്ട എളുപ്പമാണ് നമുക്ക് ഹൈറ്റ് കേൾക്കുമ്പോഴേ നമുക്ക് എത്ര ഏജ് ആണെന്നുള്ളത് കിട്ടും 137 ഇറ്റ് ഈസ് 10 years ഓക്കെ സോ 137 10 years ആണ് less than third centile ആണ് actual age എത്രയാണ് 14 years
17 years, sir.
17 years.
Yes, sir.
Okay, so significant growth retardation is there, right? Very significant growth retardation. Okay, sir, Roy Sankar sir.
Yes. She's presenting nicely. About the
Okay.
in aplastic anemia, some that Palmar changes will be there. I think some decreases and all.
Okay, correct.
Other than the trilateral thumb and all, that the crease and some changes will be there. That may give a clue.
Okay, so Sayana, what is the inference on your growth anthropometry?
Child is having a short stature. Child is short.
Okay, mid-parental height is also 25th to 5th centile. Okay. Okay, so definitely child is short stature. So when short stature is there, you have to say disproportionate or proportionate. Have you taken upper segment, lower segment ratio?
It was 0.9:1 only, sir.
So it's normal only.
Yes.
Okay, so whenever there is significant short stature, always upper segment, lower segment ratio is required. Okay, next, go ahead.
This is the anthropometric.
Okay, it is below the, okay, go ahead.
Systemic examination. Starting with the systemic examination, I would like to go further. Start with the GAT examination. Oral mucosa appears pale, and then we can see dental malformation in the oral cavity. Lower GI inspection, abdomen was distended. There was a horizontal scar of 10 centimeter present in the left hypochondrium. There is no dilated veins or visible pulsation. Umbilicus was central. All quadrants was moving equally with respiration. On palpation, abdomen was non-soft, non-tender. Liver palpable 6 centimeter was palpable 6 centimeter below the right costal margin. It was non-tender, firm in consistency and sharp border. Liver span is 16 centimeter. auscultation, the bubble sounds was normal.
Upper border of liver dullness.
It was in the 15th.
Okay. So that also should be there. Then only you can do the liver span. Okay.
Previous examination, pulse rate was 104 per minute, high volume. BP was 170 millimeter of Hg. JVP was not elevated. This patient recording appears to be normal. No visible pulsations. Apex rate was felt at the left 6th intercostal space in the mid-clavicular line. Auscultation SLS2 was normal. A grade 3 ejection systolic murmur was heard in the second left intercostal space.
So what is the inference?
A hemic murmur.
Cardiomegaly with a grade 3 SM. So what may be the reason for that?
Due to severe anemia. There is a high
Chronic anemia. Chronic anemia. So why patient is not having failure because of chronic anemia?
Because the child is I think it is they're used to the chronic hypoxia.
Correct. What is that called? But simply, it is compensated.
Compensated.
So whenever there is a chronic anemia, body is compensating for that. Compensation, somebody correct. That compensation is the word. That's all. Used to it. Correct. Body is used to it. So compensated. So there will be some cardiomegaly will be there, and grade 3 ESM can be there. Maximally there can be S3 can be there. Whereas in acute this type of anemia, baby is totally decompensated. There can be failure. Okay. Okay. Okay, go ahead.
The systems were within normal limit. Examination of the parents, there was no pallor or no splenomegaly. Coming to the summary, this is a 17-year-old girl, second born child of non-consanguineous marriage with no significant family history, diagnosed to have a hematological disorder at 6 months of age, presented with anemia requiring regular blood transfusion. Abdominal surgery was done at 5 years. Now on irregular blood transfusion, and chelation therapy, antibiotic prophylaxis, folic acid, and calcium supplements.
Sir, Roy Sankar, sir.
I heard that actually this transfusion actually more indicates that likely that thalassemia and not the hereditary spherocytis don't usually require that much frequent transfusion. And jaundice, absence of jaundice also is more in favor of thalassemias major.
Okay.
And but splenectomy, I think many times it's more needed in hereditary spherocytosis, I think. What is your impression? Then because in as thalassemia major patients, they keep on living, even they can live up to so many years, I believe even up to 50, 60 years and all. If they continue to live, previously these cases were diagnosed late, not managed, not no frequent transfusions and all. Such cases actually they never needed splenectomy also because they succumb to so many infections and all. As the longevity goes, many of them will need splenectomy. But in hereditary spherocytosis, splenectomy may be somewhat curative. These they can have a, because it's autosomal dominant condition, they can have a near normal life. They can live up to 50, 60 years and all with a reasonable productive life, unlike in thalassemias. Because they can live, they can marry, they can have children, even though the chance of inheritance is near 50%, but still they can have a near normal life. We have seen so many families like that. But whatever be this thing in thalassemia major and all, it may not be that the quality of life will be so much affected. But isn't it? Even with the new advances also.
So, Sayana, so finally, what are the differential diagnosis?
It is probably it is a chronic congenital hemolytic anemia, probably thalassemia, major. That is the transfusion dependent thalassemia.
Transmission dependent thalassemia major. So somebody has asked in the chat box also, why not jaundice? We have discussed that. Jaundice is not there. Why there is no jaundice in thalassemia? Because we are learning from our MBBS dates, triad of thalassemia is hepatosplenomegaly, pallor, and jaundice. And thalassemia, as always, we learn in hemolytic anemia. And you are telling there is no jaundice, and still you are telling it is thalassemia. Why there is no jaundice in thalassemia? You told intramedullary. Somebody has written no peripheral hemolysis. You told intramedullary hemolysis. Anybody, any other person for a better terminology? There are so many people from SAT also. Correct. Red measine. The term should be ineffective erythropoiesis. So major cause of anemia in thalassemia is not hemolysis. Even though we are considering thalassemia in hemolytic anemia group, the cause of anemia is not hemolysis per se. Hemolysis will occur in a very few percentage. Anemia is contributed because of hemolysis in a very few, 10% or 20% will be due to hemolysis. That hemolysis is mainly because of the alpha triplication. When there is beta is reduced, there will be alpha triplication and alpha Heinz bodies are formed. RBCs will be destroyed. That will produce sometimes mild jaundice, or that jaundice can be managed by the liver itself. There is not a problem. But major problem in thalassemia is just like our iron deficiency anemia. For formation of hemoglobin, you require heme and beta globin. There is no raw material. There is no beta globin. So bone marrow cannot produce hemoglobin. So it's actually we cannot say bone marrow failure. Bone marrow is there, but raw material is not there. So it is a chronic anemia due to ineffective erythropoiesis. And whatever cells are produced, there also beta globin is not there, alpha globin is replicated. So they will be destroyed earlier. So that is why some jaundice may occur, but jaundice is not mandatory. Whereas you consider, apart from thalassemia, all other hemolytic anemias, it can be hereditary xerocytosis, non-xerocytic hemolytic anemias like stomato, ellipto, and all those things. Or it can be pyruvate kinase enzyme deficiency, glycolytic pathway, glutathione enzyme deficiency, D6PD deficiency. All conditions, anemia is due to RBC destruction. So when there is anemia, always there should be jaundice. For the hemoglobin 7, 6, 5, 4, bilirubin will increase. When there is anemia, there is increased bilirubin. It has to be. It has to be. It's inversely proportional. If a hemoglobin korayundorum, but a bilirubin goodi kondirikkum. That is mandatory in autoimmune hemolytic anemia very well, except in thalassemia. So thalassemia jaundice is not mandatory because it is ineffective erythropoiesis. So considering the age of onset at 6 months, regular transfusion, some abdominal surgery, all this consideration, most probably child is having a thalassemia major. Okay, or a transfusion dependent thalassemia major. Then other differential diagnosis, it can be hereditary or other pyruvate kinase, etc., where also it can be a chronic transfusion can be there, which we have to settled by investigations and other things. Bone marrow failure syndrome. After examination, we don't have any thrombocytopenia evidence. There is no other features of Fanconi, other features of mucosal involvement. So other features of bone marrow failure syndrome is not there. It's very less likely, but I would like to investigate. Naturally, routine investigations will help you to differentiate all those things. Conditions, just a hemoglobin DC, we can rule out and we can go to the definitive test. And CKD and other things also less likely. Celiac disease, less likely requiring this much transfusion. So these are some of the differential diagnoses. At this juncture, anybody wants to ask anything? Any discussion point? Students? Sir, Purushothaman sir, onnum parannilla iduvarenu.
Illa, Sankaran, well discussed. I was listening to this.
Okay.
Anything, let us complete the case.
Okay, sir. Okay. 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 So go ahead.
Coming to the diagnosis, this is a chronic congenital hemolytic anemia, most probably transfusion dependent
Thalassemia.
thalassemia with short stature and delayed puberty.
So what is the cause of short stature and delayed puberty?
A chronic anemia per se can cause short stature.
Very good.
It can be due to the complications of iron overload,
Correct.
hypothyroidism, hypopituitarism.
Correct. Both can contribute. Chronic anemia itself has a short stature. And for example, Roy Sankar sir hereditary spherocytosis there will be not requiring blood transfusion. So one indication for splenectomy itself is a growth retardation. If there is a chronic anemia and significant growth retardation, because our hereditary point valid. Splenectomy indications for thalassemia and splenectomy indication for hereditary spherocytosis is totally different. Because here, since it is a transfusion dependent anemia, usually we will take a transfusion requirement for splenectomy. Splenectomy indication. So what is the transfusion requirement? Indication and
More than 10 to 20 transfusions per year.
No. Transfusion requirement to say that it is hypersplenism. Hypersplenism splenectomy cheyunnathu. So when will you say hypersplenism in a chronically transfused person?
200 ml of transfusion.
More than 200 ml per kg per
Year.
year. Correct. More than 200 ml per kg per year. So one vashathile transfusion ml divided by kg. So one vasham more than 200 ml per kg per year transfusion varigayanankil, that is the one indication for splenectomy in a chronic transfusion patient. Hereditary spherocytosis chronic transfusion patient, most of the hereditary spherocytosis patients are not on chronically transfused. So their indication for splenectomy is little bit different. Our indication for splenectomy or another pattern transfusion requirement it is having a significant growth retardation or features of hypersplenism. Hypersplenism defined as, when will you define hypersplenism?
When it is when the spleen is increased, it causes symptomatic changes to the child distress. Symptomatic.
That is not hypersplenism. Correct. Nasia has told 2 cell lines. That means there should be a significant enlargement of spleen with the 2 cell lines should be affected. RBC is frequent transfusion plus thrombocytopenia, or thrombocytopenia and leukopenia, or leukopenia and RBC reduction. So significant enlargement of spleen madam. Adinte kude 2 cell lines significant hypersplenism. Or as you told, indication indication that is a huge spleen which is having a symptomatic improvement. So അതുകൊണ്ടാണ് സാറ് പറഞ്ഞതുപോലെ ഒരു problem അവിടെ വരുന്നത്. That means they will leave without much transfusion, and 8 വയസ്സ് 10 വയസ്സൊക്കെ ആകുമ്പോൾ definitely invariably they will go for the splenectomy. Whereas thalassemia major requirement of splenectomy will be much more earlier. Sometimes you may not be able to do. Before that, sometimes other complications will occur. And even if you do splenectomy, the patient will die due to some other complications. So we will not see much patients on thalassemia with the adhigam patients. And so that's short stature and delayed puberty reason.
Delayed puberty is due to hypogonadism and hypopituitarism.
Due to iron storage. So other causes. What are the other things you have to check due to iron overload? What are the other problems you have to check in iron overload?
In cardiac, we have cardiomyopathy and arrhythmia.
Okay. That you told there's a cardiomegaly is there. So that cardiomegaly may be due to iron overload. We don't know. We have to check it up. Diabetes, very important. Insulin resistance. Somebody has written diabetes. So you have to look for the features of insulin resistance in a 70-year-old child. So what are the features you will look for insulin resistance?
Acanthosis nigricans.
You are not told. No acanthosis nigricans paranilla. That's the thing I told during examination and history. You can add a lot of things. But I could add acanthosis you can see, because that is very important, which will show insulin resistance. Okay. Then hypothyroidism, somebody has written hypothyroidism in the features no calm. Then parathyroid, hypocalcemia features. Hypoparathyroidism is a very common problem. So every patient on thalassemia on regular transfusion, every year you have to check for calcium, phosphorus, and alkaline phosphatase. Because parathyroid iron. So thyroid and parathyroid is very notorious to produce iron overload and complications for endocrine abnormalities. So all endocrine abnormalities you have to check. Adrenalum possible, gonadism possible, but reproductive puberty and reproductive failure. So all endocrine organs can be there. Pancreas, so diabetes and issue. So those things you have to check it. Okay. Okay. So diagnosis you have told. So some iron overload situation also you have considered. Next, continue.
Sir, as this patient was an irregular follow-up, we only have a few investigations after the child.
Investigation when type of investigation okay. So before that, how will you investigate? What are the basic investigations you will do? And what is the result you are expecting? Because you are having some diagnosis. With that, you have to tell, then only you go to the investigations, because in examination, you are not going to get any investigations. So tell me one by one, priority basis, which is the test you will do first, and what you are expecting, and how it will help you in the diagnosis.
We can do a complete blood count.
Okay.
In that hemoglobin.
So how it will help? Complete blood count, how it will help you?
Hemoglobin will be less. That is less than 2 standard deviation for the age.
Okay, hemoglobin to look for degree of pallor. We want to know the degree of pallor. You told there is pallor is there. So look for the degree of pallor, and for the management sake and other things, severity of anemia, correct. Severity of anemia to assess, you require hemoglobin. Okay, then what will you do? You will look for total count, differential count, and platelet count. Why it is important?
Total count can be increased.
Total count can be increased.
Or in case of bone marrow failure, multiple cell lines can be affected.
Okay, so multiple cell lines affection undo. Other cell lines, what happened? To know that you required a TC, DC, and a platelet count. Other cell lines. So total count can be increased. Agamo hemolytic anemia.
Yes, sir.
And don't increase on the total count.
Because the nucleated RBCs can be counted as
very good, very good. That is in the spurious zone. When you are using the whole automatic counting chamber, automatic counters, what will happen? The nucleated RBCs will count as the WBCs. So always there is a mistake, and there is an increased total count when you do it. There can be a possibility. So a spurious site or increased total count varanula sadhyata ella hemolytic anemias undu. If you use the automatic counting chamber. Very good. Okay. Automatic counters, counting chamber alla, automatic counters like 5-parter, 3-parter, 7-parter എന്നൊക്കെ പറഞ്ഞിട്ടുണ്ടല്ലോ. അപ്പോൾ അതൊക്കെ വെച്ച് ചെയ്യുമ്പോൾ there is a possibility. So all these counts are very important because other cell lines കുറഞ്ഞിട്ടുണ്ടോ. Because of two reasons. In this patient, there is spleen has been removed, but otherwise hypersplenism ഉണ്ടോ എന്നുള്ളത് നോക്കണം. Then bone marrow failure syndromes, other cell lines will be reduced. So I want to know all this. It is very, very important for me. Then
RBC indices can be done.
Red cell indices can be. Red cell indices is the most important thing. How it will help you? Red cell indices.
We can know whether it is MCV will be reduced in case of microcytic anemia. That could be.
So what are the conditions of microcytic hypochromic anemia?
It can be thalassemia,
Good.
iron deficiency anemia, sideroblastic anemia, chronic lead poisoning.
Lead poisoning, copper deficiency can produce microcytic hypochromic. These are the 4-5 conditions for microcytic hypochromic. So we want to know MCV is reduced. We are expecting a reduced MCV in thalassemia. What is hereditary spherocytosis? What will be MCV?
The MCV will be reduced, but the
Reduced.
no,
In
normal
hereditary
MCV will be-
spherocytosis. Hereditary spherocytosis, it may be normal or mild increased. Mild increased. Whereas MCHC is markedly increased in hereditary spherocytosis. Whereas MCV can be normal also. Sometimes most of the it will be normal for upper limit of normal. Whereas MCV is increased. What is the importance?
Could be megaloblastic anemia.
Correct, very good. Or
Followed
in this situation, we have discussed two conditions, chronic hemolytic anemia and chronic bone marrow failure. So what will happen in a bone marrow failure? Bone marrow failure always MCV is increased. Any situation. So anemia, first you check the MCV. When MCV is increased, always that means it's a bone marrow failure. That is another important point you should check in any case of unrelated for a practical point and for others, ITP. ITP varumbol, you check the MCV. ITP aayittu varuna patient MCV is high. You have to do the bone marrow. Because if it is MCV is high, it is a starting point of Fanconi anemia. Most of the patients, I'm not telling 100% patients, it is one indication for doing bone marrow in case of ITP. Because ITP, MCV kudi kayna and artham if there is some problem. But only thing is megaloblastic anemia MCV kuda. That is one important point. But how will you differentiate a macrocytic anemia due to bone marrow failure or macrocytic anemia due to megaloblastic?
The recti count will be reduced and then
Recti count reduced.
in the bone marrow we can see megaloblast and
Somebody has written hypersegmented neutrophils. That is one point. Hypersegmented neutrophils. That is the one thing in peripheral smear you will get hypersegmented neutrophils. Another thing is RDW. That is the important thing. Because RDW is red cell distribution width. What is red cell distribution width?
That is the variable shape due to the variable
The shape alla. Size.
poikilocytosis.
Correct. It is anisocytosis basically, not poikilocytosis, anisocytosis. Because it is actually a statistical calculation of how deviated is the size. MCV we are getting a mean corpuscular volume. This MCV MCV code it may be 108 to 112 it may be from 100 to 140. So statistical predicambo, there is a mean value and there is a measure of dispersion. Mean in dispersion would value. Mean mean median value. So MCV with the increased RDW is iron deficiency anemia. MCV low with the normal RDW thalassemia. Similarly, increased MCV with the normal RDW is aplastic anemia or bone marrow failure. Increased MCV with the increased RDW is megaloblastic anemia. So it is a one indicator always to help you to say that it is most probably is megaloblastic ano. So RDW is also important. MCHC is important because MCHC is increased in hereditary spherocytosis. And peripheral smear and recti count. Both are very important because recti count specifically you have to do. In peripheral smear you have to look for what is how peripheral smear will help you.
In hereditary spherocytosis, we can see spherocytes.
Doctor hereditary spherocytosis, first thing is we want to know whether there is evidence of hemolysis. Step by step, what is the evidence of hemolysis in a peripheral smear?
In peripheral smear, there will be
1, 2, 3. 3 point. Evidence of hemolysis in peripheral smear. 3 word terminology peripheral smear that you have to check. One is polychromasia. What do you mean by polychromasia?
Color different.
Polychromasia. What is this polychromasia?
immature.
Polychromasia is not due to nucleated RBCs. Somebody has written nucleated RBCs. So actually polychromasia is due to the increased reticulocyte count, immature RBCs. When there is increased reticulocytosis is there, the reticulocytes you can see only by the specific stain. It's called supravital staining or Berlin crysyl blue staining. You can count the reticulocyte count. In a normal peripheral smear, when you are doing with a Leishman stain, instead of the normal hue, there is a bluish tinge will be there because of the increased reticulocytes. So polychromasia indirectly means you are having more of reticulocytes, more of immature RBCs. That is one. Second thing is nucleated RBCs. When there is normoblast or nucleated RBCs, that is also suggestive of evidence of hemolysis. Third thing is some people will write the word as a leukoerythroblastic picture. That means always there is a more immature series of these cells are in the peripheral smear. So all these things suggest that there is a bone marrow immature cells are in the peripheral smear. So first you have to see that whether there is evidence of hemolysis is there or not. If there is evidence of hemolysis, then you have to look for what is the cause. There, as you told, spherocytes, stomatocytes, sickle cells, definite cells, target cells for thalassemia, etc. will come. Similarly, in case of bone marrow failure, we want to look for other cell lines and other megaloblast, other peripheral smear. Of course, in case of malignancy, consider any site of hematology case, if malignancy is there, we want to look for immature cells, blast cells, thrombocytes, if there is clumping, all those things will help you to see the peripheral smear. The reticount, of course, I told reticount will be increased in case of peripheral destruction. Reticount also in thalassemia, reticount may not be increased because same problem. It is ineffective erythropoiesis. It is not, bone marrow is not reproducing. Whereas in a peripheral destruction, like hereditary saurocytosis, G6PD, pyruvate kinase, autoimmune hemolytic anemia, reticount will be increased. So these are the first baseline investigation to see that whether, then always you have to do the biochemistry. Why biochemistry is important? Because there is also one evidence of hemolysis is there. What is the evidence of hemolysis? Indirect hyperbilirubinemia. You have to say fully answer. Indirect hyperbilirubinemia. So indirect hyperbilirubinemia is one important evidence of hemolysis. Then other evidence of hemolysis like hemopexin, haptoglobulin, all those things can be done, but routinely we will not do in the practice. So evidence of hemolysis one peripheral smear, and the increased reticulocyte count, indirect hyperbilirubinemia. This is evidence of hemolysis. Okay, LDH, very good. LDH is also another evidence of hemolysis. So evidence of hemolysis is the first check because since you told it is a chronic hemolytic anemia. Okay, then after that, what will you do? So you got an evidence of hemolysis. It is chronic hemolytic anemia. Now you want to consider which condition you want to consider. So what all conditions, or will you go to the definitive diagnosis?
Here we'll consider, as we are considering primary diagnosis is thalassemia major.
Okay.
HPLC high.
So it is HPLC or hemoglobin electrophoresis.
Hemoglobin electrophoresis.
Which is, so what is it? Hemoglobin electrophoresis and HPLC, which is better, which is superior, or both are equal?
HPLC, I could not. Question was not clear, sir.
Yes. Nesia can answer that question. Nesia?
Yes, sir.
Unmute yourself and tell the answer.
HB electrophoresis is better, sir.
Why HB electrophoresis is better? Nesia, please answer fast. Time. What is the difference between electrophoresis and HPLC? Somebody has written HPLC is better, quantitative. Okay. So basically in electrophoresis, as rightly that person has pointed out, because that is showing Redmi. I don't know. That is why I'm not that person. I don't know that student's name. That is why I don't know. It's written as Redmi. Okay. So what is electrophoresis is usually will give you the answer which is a major band. It's a hemoglobin F, hemoglobin A, hemoglobin A2. So normally in individuals, A and A2 will be there. F may not be there in a 17-year. So you are supposed to get only the major band at hemoglobin A and a minor band at hemoglobin A2. So instead of this, in this case, if you are doing electrophoresis, you are getting a major band at hemoglobin F, no band in hemoglobin A, and a minor band in hemoglobin A2. There is no confusion in the diagnosis. So in this patient, electrophoresis and HPLC is equally good, will not give much information. HPLC is a high performance liquid chromatography, which is a mechanism, actually, sorry, that is a machine we are using it. Same HPLC which we use for amino acid and other thing. But here we will use a hemoglobin variant analysis. That is the test actually, hemoglobin variant analysis, where you will get the actual quantity of the peak, where you will get hemoglobin F 97%, hemoglobin A2 2.5%, or hemoglobin, some other hemoglobin 0.5 or something like that. So there you are getting the actual values. So that is an advantage. But in a situation like thalassemia intermediate, that is non-transfusion dependent thalassemia, or a combination of E beta, S beta, and all those things, that situation, electrophoresis is not useful. Because in a thalassemia trait or thalassemia carrier, hemoglobin A2 cutoff should be more than 3.5%. If in a normal individual you will get a major in A and minor in A2. In thalassemia trait also, you will get a major band in A and a minor band in A2. You may not be able to do the actual quantification. That actual quantification, you required HPLC. So in some situation, HPLC is definitely better than electrophoresis. But that doesn't mean that HPLC is always contributory. HPLC is also having certain limitations. For example, there are so many hemoglobin variants are there. Some of the hemoglobin variants will go together in HPLC. Classical example which we will use for teaching purpose is hemoglobin E and A2. Because E and A2 cannot be separated in HPLC. Always it will go elute together. So in a case with the hemoglobin E beta thalassemia, if you do the testing, you will get hemoglobin A2 as 42%, 45%, which is absolutely not possible for A2. A2 maximum will be 5 or 5.5 only. So when it is comes as 40% or 50%, that means E is there. That E and A2, if we want to separate, practically speaking, that is enough. E and A2 A2 50 നമ്മുടെ ഡയഗ്നോസിസ് ഇ ബീറ്റ ആയിരിക്കും, അത് അച്ചിട്ടായിരിക്കും, അത് മാത്തമാറ്റിക്സ് ആണ്, വേറെ ഒരു കണ്ടീഷനിൽ അങ്ങനെ വരാൻ പറ്റൂല. ബട്ട് ടെക്നിക്കലി സ്പീക്കിംഗ്, ഇഫ് യു വാണ്ട് ടു കൺഫേം ഇറ്റ്, യു വാണ്ട് ടു ഡു electrophoresis where E and A2 can be separated. And this electrophoresis can be in acid medium and alkali medium, where this separation is different. So these things you don't have to know in detail, but you should understand that both are not same. Some situation electrophoresis is better, some situation HPLC is better. If you want to know the quantification, you have to do the HPLC. Okay. So you will do the HPLC quantification, which will help you to know that it is what is the actual percentage of each hemoglobin variant, which will confirm the diagnosis. If it is hereditary spherocytosis, how will you diagnose?
In hereditary spherocytosis, we can go for
What is a definitive diagnosis for hereditary spherocytosis? But thalassemia gold standard is hemoglobin quantification. That's gold standard, not genetic testing. Hemoglobin quantification, that is enough. Whereas in hereditary spherocytosis, what is a test which will confirm that it is hereditary spherocytosis?
osmotic fragility.
No, there is not a single test. That is the problem. Even genetic study is not the correct answer. It is not possible. Because in osmotic fragility, there are situations where osmotic fragility can be normal, and there are situations where osmotic fragility can be increased in other conditions. Osmotic fragility, just fragility is there. That's all. Similarly, spherocytes in the peripheral blood. What are the conditions where spherocytes in the peripheral blood will be there? One is hereditary spherocytosis. Then,
In case of hemolysis, also we can see.
what hemolysis? Hemolysis is not a general answer. Hereditary spherocytosis hemolysis. One is hereditary spherocytosis. Then autoimmune hemolytic anemia. Then somebody അടിച്ചോണ്ടേ ഇരിക്കുകയാണ് ആൾക്കാർ. Burns, Wilson's disease. Okay, Burns, Wilson's disease. HUS spherocytes alla. HUS actually it is a what you can say, it is a schistocytes, helmet cells, there is a breaking down cells again. So usually we will not consider spherocytes. The DDI sadharana HUS consider cheyarilla. Classical conditions are hereditary spherocytosis, autoimmune hemolytic anemia, Wilson's disease, Burns. ഇതെല്ലാം സ്പിറോസൈറ്റ്സിന്റെ പല കോസുകളാണ്. And the Clostridia, correct. Clostridia sepsis, very important. Somebody hasn't done. Clostridia sepsis. Snake bite, very good. Snake bite. So there are so many conditions are there. So spirocytes confirmed ano alla. Osmotic fragility confirmed ano alla. MCHC confirmed ano alla. So it is confirmed alla. So there you usually require a criteria, just like the rheumatic fever like a criteria bole. There is a criteria are there. 4-5 criteria വെക്കുന്നു. അതിനകത്ത് more than 3 ഉണ്ടെങ്കിൽ compatible ആണ്. There is criteria. One is there should be evidence of hemolysis. Osmotic fragility is increased. Third thing is there is a spherocytes in the peripheral blood. MCHC is increased and contributory family history. If 3 or more is there, it is confirmed hereditary spherocytosis. 2 is there. Somebody has asked about flow cytometry. There are so many advanced techniques are there: electrocytometry, flow cytometry, and one more thing is there which I'm not remembering now. I was trying that. Usually, I'm MCQ question test on that. These things are not routinely done, not routinely required also. These 4 criteria which reasonably we can clinically diagnose a patient is having hereditary spherocytosis or not. And if it is hereditary spherocytosis, we can do genetic test. EMA, correct. EMA is another test which can be done, but these things are only theoretical thing. Routinely, nobody is using for the clinical diagnosis of hereditary spherocytosis. Clinically, you can diagnose with these criteria, and if it is there, you can do the genetic testing, which will help you to confirm the diagnosis. And when will you suspect non-spherocytic hemolytic anemia? Because our clinical diagnosis is thalassemia, spherocytic hemolytic hereditary spherocytosis, or a non-spherocytic hemolytic anemia. Pyruvate kinase ano, stomatocytosis ano. These things are clinically you cannot differentiate. Even with the basic investigations, you cannot differentiate. So there, hemolysis and evidence on the autoimmune hemolytic anemia, autoimmune hemolytic anemia, of course. DCT you can do, which will easily pick up. It is autoimmune hemolytic anemia. Rest along with a bracket because these things are very, very difficult to say. And some of the Heinz bodies are G6PD, that is correct. There is can be Jesus. So that those type of conditions altogether we will call it as a non-spherocytic hereditary hemolytic anemias, where glutathione deficiency is there, pyruvate kinase deficiency is there. These conditions will come into the different picture. Because intravascular hemolysis clinically intravascular hemolysis and evidence thalassemia on chronic blood loss, always you have to consider the over the above thalassemia. Sometimes there can be immune hemolysis also can be there because of minor blood group incompatibility. Actually, this patient, Vinitha, I am remembering because Vinitha was previously coming to SAT for regular transfusion, and she is totally not on regular transfusion. Even though we tell it's a 7 varanam, 8 varanam, 9 varanam, she will not come. Okay, so but always, and once she had a severe acute hemolysis after transfusion, and at that time DCT was strongly positive, intravascular hemolysis was there. So we have treated with the steroids because steroids has to be given because of the minor blood group incompatibility, because of regular transfusion. That is why in a thalassemia guidelines, we will tell that always before doing the you have to do the minor blood group testing. Because after that, you cannot do minor blood group. Because we have blood group, major blood group, minor blood group, transfusion regular transfusion difference. Why this regular transfusion people are developing intravascular hemolysis because of minor blood group incompatibility, whereas in a normal person is not getting it. Why?
Because of the Repeated transfusions would be of because it is not regularly tested, it can be there.
Regularly? Because normally if you transfuse a person, upper and minor blood group incompatibility undagunnunde. Nobody is going to check. But that is minor blood group undagunna antibody level will be very minimal, which is not enough to produce a clinical hemolysis. Clinical hemolysis and complication undavanulla sadhyatha a minor blood group incompatibility konde valare koravan. Whereas in a case where there is a repeated transfusion, this antibody level will be gradually increased. One level suddenly it will produce significant hemolysis, which will produce intravascular hemolysis. So there you require some treatment. As a minor blood group would transfuse here. Blind blood group because blood coombs system, everything will be hemolysis clumping. So that is why these patients are minor blood group so that a transfusion reaction a minor blood group would blood regular transfusion that also you have to think about it. So I think since time going, so I'm just cut shorting, and you can tell the investigations, then we will go to the final diagnosis and management. What are your investigations? You can just show.
We only have investigations of hemoglobin was repeated hemoglobins. Child only came from blood transfusions. We have pre-transfusion hemoglobins, which was done at 31st 9. It was 7.4.
So you feel this pre-transfusion hemoglobin is good?
No, sir.
So what is the recommended pre-transfusion hemoglobin in a thalassemia?
It is 9.5 to 10.5.
So what is the difference between hypertransfusion and supertransfusion?
Hypertransfusion, it will be more than 12.
Supertransfusion? No, you are confused. Supertransfusion is maintaining pre-transfusion hemoglobin above 12. Hypertransfusion is above
12.
Hyper edana, super edana.
Super is between 10 to 12 and hyper is above. Hyper is above 10 to 12. Between 10 to 12.
12. Super is about 12. That's a general. Super is most of the time, at least in Indian context, we have to maintain a moderate transfusion regime. That is, hemoglobin should be maintained above 9. Above 9. So that is the difference between transfusion therapy in a thalassemia and transfusion therapy in other hemolytic anemias. That's a confusion. Because other hemolytic anemias, we will tell that we will transfuse when hemoglobin is below 7. Hereditary spherocytosis, non-transfusion dependent thalassemia, pyroid kinase, it is below 7. Because there we know that hemoglobin in a coronary it will somewhere around 7.5, 7.8, 8 like it will not go below 7. So if you transfuse, we are unnecessarily giving blood transfusion, and transfusion related complications are more to occur. But as far as thalassemia is concerned, we know beta globin is not there. Thalassemia major is concerned, beta globin is not there. So when you not transfuse, this 7 will be within 1 week, it will be 5. Another 1 week, it will be 3. So they are transfusion dependent. So when you give the transfusion at below 7, 6, if you consider a transfusion you are giving at 6, like in 5.2 or something like that, when with a 10 ml per kg or a 15 ml per kg, again 2 gram percentage hemoglobin will increase. 5.2 will go to 7.2. After 2 weeks, again it is 5.2. Again it is going to 7.2. So in the all 365 days throughout the year, patient will be anemic. So patient will have all complications of chronic anemia. You are giving transfusion, but it doesn't have any benefit. Always patient is in chronic anemia, so hemolytic phases will occur. And if you take instead of that, if you give the transfusion at 9, it will go to 11. Again, it will come to 9. Again, it will go to 11. So always the hemoglobin will maintain between 9 and 11, and there is no chronic anemia. Patient can have a normal life, normal mental ability. Child can learn, child can do all activities, and extramedullary hematopoiesis is less. Splenomegaly will come down. Splenomegaly will not increase. And if you take the total blood transfusion requirement in a year, if you maintain in a hemoglobin at 9 to 11, the transfusion requirement will be less than you are giving transfusion at the 3 or 4, where you will give 3 or 4 pint of blood to reach at the 9. So there in thalassemia, transfusion always should be maintained a hemoglobin of somewhere around 9, 7, 5.25, 3, everything is wrong. Whereas in pyruvate kinase and other, below 7 matram kodukka, so once in a 3 months, once in a 4 months, or once in a 6 months, or once in a year, you may require 1 or 2 transfusion. As I mean, 7 regular transfusion requirement unnecessary blood. So that's a judgment. So first few transfusions matram thalassemia, because somebody has some student somewhere they have written that in thalassemia also below 7 in first few transfusions, because we don't know the transfusion requirement. So ആദ്യമായിട്ട് ഞാനൊരു 6 മാസത്തിൽ 7 മാസത്തിൽ കുട്ടിയെ കാണുമ്പോൾ അപ്പോൾ നമ്മൾ 8 9 നോക്കത്തില്ല, we will wait എത്ര ദിവസത്തിലാണ് below 7 പോകുന്നത്. First few days it may be somewhere around 5 weeks ഒക്കെ ആയിരിക്കും. 3 weeks ഒന്നും വേണ്ടി വരാറില്ല. 6 monthsലൊക്കെ എപ്പോഴും ഒരു 5 weeks വരെയൊക്കെ മെയിൻറ്റെയിൻ ചെയ്യാൻ പറ്റും. Then we know that 5 weeks 4 weeks transfusion is required. Then you maintain a hemoglobin of at least 8.59 so that all these complications can be prevented. And why this TC is high, 19,800, 21,000, 17,400? What is the reason?
These nucleated RBCs can be counted as
another reason.
Other cell lines are as the RBCs reduce, other cell lines.
So what is the change in cell lines after splenectomy?
After splenectomy, there can be increase in TC and
increase in platelet count, both. That is very, very important. That is one complication of splenectomy. After splenectomy, thrombocytosis can occur, which is actually dangerous. What is one cause for thrombosis, post-thrombosis in a splenectomy? So significant thrombocytosis can be there. Some amount of increased TC can also contributed by post-splenectomy. Post-splenectomy, there can be increased WBC count. Okay. MCV 73, MCH 25, MCHC. Okay. Ferritin is 5,200. So what about your comment on ferritin?
Ferritin is there is a significant iron overload, sir.
So when will you start chelation therapy as per ferritin?
Ferritin is more than 1,000 nanogram per ml.
So when in a thalassemia in a transfusion dependent patient, after how many transfusion usually it will reach above 1,000?
16 to 20 transfusions.
Okay, 10 to 15 or around 15 transfusions. So that is around 1 year. 1 year 52 divided by 5 kutti around 10 transfusion. So around 1 year, 1.5 years, you have to start the chelation therapy. Ferritin is definitely high. That means that there is a chronic iron overload is there. Okay. And it is very difficult to maintain below 1,000. That is 100% I am agree. Even if you give iron chelation therapy, below 1,000 is very difficult. Stringent dietola therapy from the first itself is required to maintain a serum ferritin less than 1,000. Okay. Next. Other investigations?
Other investigations, we're having peripheral smear. In that there was a moderate anisopoikilocytosis with moderate hypochromia.
Okay.
Chromatopsis can also be seen. Definite target cell was
okay.
WBCs are normal. Red cap was adequate and seen in clusters.
So what is Howell-Jolly bodies?
Howell-Jolly bodies are seen in case of
remnant of RBC is seen in post-splenectomy. So it is another feature you can see as the post-splenectomy individuals. You can see the Howell-Jolly bodies. Okay. Okay. Then next.
Next we are having only chest X-rays.
So cardiomegaly is there. Okay. What is the CT ratio?
CT ratio is 67.
67%. Okay. So another problem in thalassemia is a pulmonary arterial hypertension they can develop. In is pH features are there?
No, sir, there is no.
Okay. Okay. Clinically also there is no pH.
We are not having any other investigations, sir.
Oh, no other investigation has been done. Okay, electrophoresis ഒക്കെ ചെയ്ത് കാണത്തില്ലേ? Genetic testing ചെയ്ത് കാണുമല്ലോ.
They are not having the details, sir. They came here at 15 years. They are not having any papers.
I know. Now they are getting transmission there. So electrophoresis results also you don't have.
No, sir. Not having.
Okay. So what is the role of genetic testing in thalassemia?
In genetic tests, we can see that whether the mutations are there.
For the diagnosis, it is actually not required. For confirmation of diagnosis as well as genetic counseling and prenatal diagnosis. Because when you want to do what is the recurrence risk in next pregnancy, they are asking, Vinita's mother is asking to you, we want to have the other child. What's the chance of recurrence in next pregnancy?
5% chance.
25% chance, because it is an autosomal recessive disorder. And how you can help them?
We can advise a screening test for them.
Why screening test? What do you mean by screening test? എന്താണ് സ്ക്രീനിംഗ് ടെസ്റ്റ് ഉദ്ദേശിച്ചത്? എനിക്ക് മനസ്സിലായില്ല. അച്ഛനും അമ്മയുടെയും കാരിയർ അനാലിസിസ് ആണ് ഉദ്ദേശിച്ചത്. അത് ചെയ്യാം, പക്ഷെ invariably they will be carriers, because autosomal recessive disorders, parents are invariably carriers. Almost, I cannot say 100%. There are some situations where one of the parent carrier ആയിട്ട് കുട്ടികൾക്ക് autosomal recessive വരുന്ന conditions ഒക്കെ ഉണ്ട്. Genetic mechanisms are there, but that contributes only 1% or something like that. It's extremely rare. Do you know any condition where one of the parent is a carrier and child is getting an autosomal recessive disorder? Any genetic principle? Anybody? Any PGs? Imprinting, not imprinting, something else related to imprinting. Imprinting പഠിക്കുമ്പോൾ തൊട്ടടുത്ത് പഠിച്ച paragraph. Correct. Uniparental disomy. So uniparental disomy is the genetic mechanism where there can be, who is this BBH? Who is that BBH? BBH Arana, can you tell your name? Dr. Pansira. Okay. So it is uniparental disomy from Bangalore Baptist Hospital. Okay, good. Okay. So it is a uniparental disomy. Uniparental disomy is a one condition where it can be both genes are coming from the same parent. So one parent will be a carrier, another parent will be normal, but child is getting both the genes from the one parent and they can be the disease. So it is just, I have asked for an overlook geneticist to choice. It is not important, but practically speaking, both the parents will be carriers. But carrier testing in other hemoglobin A2 and a role just confirmed. Anyway, we have to do genetic testing in the parents, because that mutation we have to confirm in both parents before doing prenatal diagnosis. So you can advise them that you can do the prenatal diagnosis at what week, which procedure we will do, at what week we will do.
Chorionic villus sampling can be done at 10 to 12 weeks.
9 to 12 weeks, 12 weeks. 9 to 11 plus 6 weeks. Before 12 weeks, always there's a possibility of oromandibular hypogenesis. Abnormalities are there. 12 weeks, you can do the chorionic villus sampling, fetal DNA testing, and you can tell that whether baby is affected or not, and they can take the formal decision depending on whether baby is affected or not. So in that way, they can do you can help them through genetic counseling to have the normal child. So that is very important part of the genetic testing. And genetic testing, what genetic testing we will do? We will do DNA testing. Sequencing, simple sequencing is enough, because this thalassemia is having only 3 exons and 2 introns. It's a very small gene, and more than 300 mutations are known, but it is ethnicity specific. And commonest mutation is IVS15G to C. That is intervening sequence. Intron 5th position G is changed to C. Intron 1. That is a commonest IVS15G to C. That is the commonest mutation. 70% of Indian population thalassemia patients are having IVS15G to C. Rest of the 30% to 25% is having 4 common mutations. 5 mutations 95% cover out. 5 more mutations 99% cover. So even if it is 200 to 300 mutations known, around 5 to 10 mutations ചെയ്തു കഴിഞ്ഞാൽ ചെയ്യാം. ഇപ്പൊ നമ്മൾ അങ്ങനെയല്ല ചെയ്യുന്ന sequencing of the entire gene we will do, which will help you to know ഞാൻ പറഞ്ഞ പോലെ hemoglobin E, hemoglobin S, hemoglobin D, Punjab, all hemoglobin variants can also be identified except deletions. Deletions cannot be identified by sequencing. Deletions will be missed. അത് വളരെ rare ആണ്. Deletions ഉള്ള കേസുകൾ ഉണ്ട്. അത് നെക്സ്റ്റ് പേസ് ചെയ്യും. താലസീമിയ പിക്ചർ ആണ്, ഇലക്ട്രോഫോറസിസ് താലസീമിയ പോലെയാണ് ഫിറ്റ് ചെയ്യുന്നത്. പക്ഷെ നമുക്ക് ബീറ്റാ ഗ്ലോബിൻ സീക്വൻസിൽ കിട്ടുന്നില്ല എന്നുണ്ടെങ്കിൽ വി വിൽ ലുക്ക് ഫോർ. ഞാൻ അത്ര ഡീറ്റെയിലോട്ട് പോകുന്നില്ല. യു ക്യാൻ ഡു MLPA deletions. അത് ഭയങ്കര റയർ ആണ്, എക്സ്ട്രീംലി റയർ ആണ്. So DNA sequencing can be done to look for thalassemia mutations. Okay, that is about the genetic counseling, prenatal diagnosis, counseling, all those things we have told. How will you manage this patient? This patient, how will you manage? And ideally, how should I manage a thalassemia patient? What is the ideal management of thalassemia? Standard of care?
Blood transfusions.
No. Somebody asked you standard of care. It is what the treatment they will do? Bone marrow transplantation. Hemopoietic stem cell transplantation. Nowadays, thalassemia transfusion alla treatment. Treatment is hemopoietic stem cell transplantation. Bone marrow transplantation nu paranjalum HSCT nu paranjalum same aanu. Previously we used to say the terminology of BMT, but now we use the HSCT. Both are same. Now peripheral smear nu edukam, bone marrow nu edukam, allengi cord blood nu edukam. Evide nu eduthaal it's okay, but it is a bone marrow or hemopoietic stem cell transplantation. That is the standard of care of thalassemia, major especially, because as sir told, Roy Sankar sir told, patient is having a very poor management, transfusion accounting, lot of complications can be there. So hemopoietic stem cell transplantation is the treatment of choice. അതായിരിക്കണം ഫസ്റ്റ് എപ്പോഴും നമ്മൾ പ്രിഫർ ചെയ്യുന്നത്. ഏർലിയർ ആയിട്ട് തന്നെ ചെയ്യാനും നോക്കണം. Because the response rate is depends upon most important 2-3 factors are, one is iron overload, second thing is liver damage. Iron overload kondo, recurrent transfusion kondo, hepatitis C kondo, if patient developed a hepatic failure or hepatitis C problem or increased enzymes, and success rate will be low. So most important 2 factors determining the bone marrow transplant is iron overload and this hepatic involvement. So അതുകൊണ്ട് early transplant എന്ന് പറഞ്ഞാൽ നമുക്ക് 6 മാസം ചെയ്യാൻ പറ്റില്ല. 6 മാസത്തിൽ ഡയഗ്നോസ് ചെയ്താൽ അറ്റ്ലീസ്റ്റ് ബൈ 2 years or 2.5 years ട്രാൻസ്പ്ലാന്റ് ചെയ്താൽ it is having excellent response. And I think we are also following the same regime, because ലളിത കൈലാസ് മാഡത്തിനൊക്കെ അറിയാം. മാഡം ഒക്കെ ഉള്ളപ്പോൾ ഞാനിവിടെ കഴിഞ്ഞ് വന്ന സമയത്ത് we are having somewhere around 16-17 patients on transfusion. ഇപ്പൊ നമുക്ക് we don't have any patients practically. വളരെ കുറഞ്ഞ പേഷ്യൻസ് ഇല്ലെന്ന് തന്നെ പറയാം. റെഗുലർ ട്രാൻസ്ഫ്യൂഷൻ ഉള്ള താലസീമിയ മേജർ വളരെ കുറഞ്ഞു. Because of 2 reasons. One is അന്നത്തെ old patients ഒക്കെ death ആയി, frankly speaking. 2-3 patients died. And some of the patients, just like these adult patients, Vinitha, some of the other patients, 4-5 patients are there. But that patient I know, Vinitha അവിടെയാണെന്ന് എനിക്കറിയാം. അതേമാതിരി 4-5 patients are in the adult medicine. And most of the middle ഉണ്ടായിരുന്ന patients എല്ലാം നമ്മൾ ട്രാൻസ്പ്ലാന്റ് ചെയ്തു. We are having 7 or 8 transplant we have done in last 7-8 years. And 2 patients ഒഴികെ ബാക്കി 6 patients ഇപ്പൊ നോർമൽ ആയിട്ട് ജീവിക്കുന്നു. And nowadays our dictum is thalassemia major diagnose ചെയ്യുക, somehow try to transplant within 2 to 3 years so that they don't require a transfusion regime. So I don't think ഇനിയുള്ള കാലത്ത് thalassemia നമ്മൾ ട്രാൻസ്ഫ്യൂസ് ചെയ്തുകൊണ്ടിരിക്കാൻ പറ്റൂല, because transplantation is the treatment for thalassemia major. അങ്ങനെയേ പറയാവുള്ളൂ. Standard of care is transplantation. If transplantation is not possible, then regular transfusion therapy with the iron chelation, look for complications and complications management. Other, I think again 1 hour is required to do all those things, management and everything. There are so many issues where they are not on regular transfusion. So transfusion directly കിട്ടിയിട്ടില്ല, അതിന്റെ complications ഉണ്ട്. Iron chelation, അതിന്റെ complication. 17 years ആകുമ്പോൾ we have to do the hepatitis B, C, D അതൊക്കെ നോക്കണം, HIV നോക്കണം, regular endocrine management നോക്കണം, diabetics management നോക്കണം, cardiac and overload. So how will you look for iron overload? That's a common question usually asked. Iron overload, how will you assess? Serum ferritin മതിയോ, any other thing is required?
Liver concentration, liver iron concentration can be checked, sir.
Okay, correct. ആയിട്ട് നമ്മൾ നോക്കണമെങ്കിൽ you have to do liver biopsy and we have to look for actual iron overload in liver is the ideal way of doing it. But nowadays nobody will do it because it is an invasive procedure. So what we can do? We can do the MRI T2 ചെയ്യാം അല്ലെങ്കിൽ സ്ക്വിഡ് ചെയ്യാം. Both can be done. Squid is much more better, but squid ഇപ്പൊ കുറച്ച് എല്ലായിടത്തും അവൈലബിൾ ആയിരിക്കത്തില്ല. MRI ആണെങ്കിലും it is a MRI with T2 ആണ് ചെയ്യേണ്ടത്. It is a separate protocol is there. So every person may not be, a radiologist may not be well versed with it. ചുമ്മാ MRI ഫിലിം എടുത്ത് നിങ്ങളുടെ തന്നാൽ you cannot conduct it. They have to do it with separate sequences, and separate software has to be used to identify what is the iron content in the MRI T2 weightage. So it's a separate protocol on it, and radiologist നമ്മൾ നേരത്തെ അറിയിക്കണം. It is for the iron overload, and they have to look for the liver and heart. Both നമുക്ക് നോക്കാൻ പറ്റും. So that is the MRI വഴി ചെയ്യാം അല്ലെങ്കിൽ സ്ക്വിഡ് വഴി ചെയ്യാം. That is now the recommended method to look for iron overload. Every year ചെയ്യണമെന്നാണ്, but practically നമ്മുടെ നാട്ടിൽ ചെയ്യാൻ പറ്റത്തില്ല, because MRI ഉണ്ടെങ്കിലും most of the MRI മെഷീൻസിൽ എല്ലാത്തിലും ചെയ്യാൻ പറ്റില്ല. ഏർലി sequence 1.5 ടെസ്റ്റിലേക്ക് പണ്ടത്തെ MRI മെഷീൻസിലൊന്നും may not be able to do. Newer MRI machines protocol വേണം, and the radiologist also should be able to know how to look into this MRI T2 calculation. What is the iron overload? അത് ഉണ്ടെന്നുണ്ടെങ്കിൽ that is equally. And how will you manage iron overload?
Well, chelating agents can be started.
So what are the chelating agents? And
Now we have the available IV agent is a desferoxamine.
okay.
Oral agents are defiperon and defiperon and
Deferasirox. So there are the two oral agents, deferipron and deferasirox, and desferrioxamine is the IV. IV is subcutaneous actually. Deferasirox actually should be given in the continuous. It should be subcutaneously 8 hours over the night and 5 to 6 days per week. And that's in the regime. Previously, deferasirox മാത്രമേ ഉണ്ടായിരുന്നുള്ളൂ, but in the problem is it's subcutaneously infusion pump വഴി കൊടുക്കണം. And in some side effects എല്ലാത്തിനും ഉണ്ട്. അതിന് some side effects like deafness is there. Deferasirox in deafness ഉണ്ട്. There are some side effects are there. Most important thing is compliance was very poor. Children ഇങ്ങനെ പമ്പ് വെച്ചോണ്ട് രാത്രി മുഴുവൻ കിടക്കണം. So it is difficult. So oral interest വന്നു. So first oral agent came is deferapron. But deferapron, somebody has asked, Shanavas asked a time ആയില്ലേ? Sorry, we will stop. So deferapron, deferasirox, and deferapron is having its own side effects like arthralgia and other things are there. And deferasirox is a safety profile is better. So that can do that also. Okay, Roy Sankar sir, sorry, ഞാനിങ്ങനെ പറഞ്ഞുകൊണ്ടേയിരുന്നു.
No problem. It is actually genetics topic itself.
Okay.
I also enjoyed. In fact, I also refreshed my knowledge before the class.
Shanavas, I think we will stop here. നമ്മള് ഇനിയും താലസീമിയ പോയാൽ തീരൂല. ഒരുപാട് ഇനിയുണ്ട് താലസീമിയയിൽ പറയാൻ. താലസീമിയ ഇന്റർമീഡിയറ്റ് molecular mechanisms. So many things are there. Thalassemia, I don't think it will be possible to cover. But I think major questions ചോദിക്കുന്ന പുഷ്പവർദ്ധന സാറേ, major questions ഒക്കെ കവർ ചെയ്തില്ലേ സാധാരണ ചോദിക്കുന്നത്?
Well discussed there. Almost.
One more point which I would like to. This iron deficiency anemia is very common in different age group, including adolescents also. It's very common. This thalassemia minor is the immediate differential diagnosis for iron deficiency anemia. Suppose they are not any patient not responding to sufficient quantity of oral iron and other bleeding we are taking care of, and the patient is not responding, always think of thalassemia minor. And by the simple test, we can, in fact, by Nestroff standard, we can simply screen them in areas thalassemia is very common. And nowadays, the national NMC insists that there should be a thalassemia clinic in every medical institution, including private medical college. We also have a thalassemia clinic, but we don't have any patients.
Correct. And now there's a national program is there. Comprehensive Hemophilia Center and Hemoglobinopathy program is there, where government is pumping a lot of pumping money and lot of things. That is why I told now we are having a lot of support. Thank you, sir. Ashok sir has given a, and thank you, sir. My teacher, thank you, sir. And so there is a national program is there. Through that program, we can have a lot of transplant volume help കിട്ടുന്നുണ്ട്. Government of India help ഉണ്ട്, or Call India help ഉണ്ട്. So in thalassemia major, all students nowadays only treatment is transplant. Because ഈ chronic transfusion therapy ഇപ്പോൾ ഉള്ള പേഷ്യൻസ് ഒന്നും ചെയ്യാൻ ഒക്കത്തില്ല. അതാ ഞാൻ പറഞ്ഞേ, ഇപ്പൊ ഞാൻ നമ്പർ കുറഞ്ഞതെല്ലാം ട്രാൻസ്പ്ലാന്റ് കൊണ്ടല്ല. ഇപ്പൊ ഇരിക്കുന്ന പേഷ്യന്റ് നമുക്ക് ഇപ്പൊ വിനിതയ്ക്ക് ഇങ്ങനെ മാനേജ് ചെയ്ത് പോകാനേ പറ്റുള്ളൂ. ഇനി ട്രാൻസ്പ്ലാന്റ് ഒന്നും വിനിതയ്ക്ക് പോസിബിൾ അല്ല. പക്ഷേ ഇനി വരുന്ന thalassemia major-ന് if it is thalassemia major diagnosed, try to do transplant. Because transplant is a best treatment എന്ന് പറഞ്ഞാൽ success rate around 70% ആണ്. നമുക്ക് ഹാപ്ലോ തന്നെ ഇപ്പൊ എല്ലാവരും ചെയ്യും. Very good immunosuppressive support is there. And most of the centers having a success rate of 70 to 80%. Still there is a 20% is there, mortality and some other complication, GVHD extra is there. But still around 70 to 80% success rate is there for thalassemia. Gene therapy is coming for thalassemia, but I think it will take some more time. Gene therapy, transplant ആയിട്ടുള്ള gene therapy ആണ് കൂടുതലും thalassemia try ചെയ്യുന്നത്. That is autologous gene therapy. Take the blood of the patient, do the gene therapy and give to the same patient. Autologous stem cell transplant plus gene therapy is one area they are most probably doing it. Okay.
Well discussed, Shankar. I think thalassemia is a topic, I think, which we can discuss at any length, even 3-4 hours at a stretch. But I think you are incorporated genetics also. But just one question, that is, as you said, Vinita, this is one of the example, because Vinita came to us just because of me. That is because she was transferred to the adult medicine. So
Yes.
pediatrician, because we referred her to the adult medicine and she was not feeling comfortable at all with the MCH.
Correct.
And so actually, naturally, as you think, private medical college, it's very difficult, but somehow or other we managed to give her some free drugs and free transfusion and all. But can we do something? Because nowadays she's not getting, sometimes we used to give her money to buy the chelating agents. So some means by which can she be enrolled in the Tarolam now?
No, madam, we are having a program where we will give all chelating agents and other supporting agents free for all thalassemmic patients.
From where actually? DC.
Actually അത് നമ്മുടെ SIT തന്നെയാണ് കൊടുക്കുന്നത്. And ഇതിനകത്ത് ചെറിയൊരു പൊളിറ്റിക്സ് ഉണ്ട്. ആക്ച്വലി പ്രോബ്ലം എന്തെന്ന് പറഞ്ഞാൽ നമുക്ക് അഡൽട്ടിനെ കിടത്താൻ പറ്റൂല. നമ്മുടെ ഇപ്പൊ നമുക്കൊരു 3 പേഷ്യന്റ് ഉണ്ട്, തിമോത്തിയോസ്, ഹാരിസ്, ആമീന, അല്ലമീൻ. ഇവരൊക്കെ 16-17 വയസ്സായി. ഇവരെയൊക്കെ നമ്മൾ വി ആർ ട്രാൻസ്ഫർ ടു മെഡിസിൻ. മെഡിസിനിൽ പോയിട്ട് അവരവിടെ ഭയങ്കര പ്രശ്നമാണ്. ഡെയിലി ഇവിടെ വന്ന് വഴക്കുണ്ടാക്കും. SIT-യിൽ എങ്ങനെ ഞങ്ങളെ പൊന്നുപോലെ നോക്കുമായിരുന്നു, മെഡിസിനിൽ പോകുമ്പോൾ ഞങ്ങൾ എവിടെയെങ്കിലും കൊടുത്ത് ബ്ലഡ് കൊടുക്കുന്നു. ആൻഡ് ആമീന ആമീന ഇസ് ഒരു ഫീമെയിൽ, ഷീ ഈസ് വെരി ഹാപ്പി. വളരെ നന്നായിട്ട് പറയുന്ന കുട്ടിയാണ്. അപ്പൊ ആ കുട്ടി പറയുന്നത് ഒരു ദിവസം ബ്ലഡ് കൊടുത്തോണ്ടിരുന്നപ്പോൾ അപ്പുറത്തെ ഒരു ഡെഡ് ബോഡി വാസ് there. Because അവിടെ ഡെത്ത് ഒക്കെ ഭയങ്കര കോമൺ ആണല്ലോ. So they are very upset, these children are, by seeing this death and other things. അപ്പൊ അതുകൊണ്ട് അവര് വളരെയധികം അപ്സെറ്റ് ആണ് മാഡം പറയുന്ന പോലെ. അപ്പൊ ഞാൻ പറഞ്ഞ നമുക്കിപ്പോ മൊത്തത്തിന് എടുക്കാൻ പറ്റൂല, ബിക്കോസ് ഇവിടെ അഡൽസിനെ കിടത്തി കൊടുക്കാൻ ഒരു പ്രാക്ടിക്കൽ ബുദ്ധിമുട്ട് വരും. സോ നമ്മൾ ഈ പേഷ്യൻസിന് ചെയ്യുന്നത് ട്രാൻസ്ഫ്യൂഷൻ അവർ മെഡിസിനിൽ തന്നെ കണ്ടിന്യൂ ചെയ്യുന്നു ഇപ്പോഴത്തേക്ക്. ആൻഡ് കീലേഷൻ തെറാപ്പി നമ്മൾ കൊടുക്കുന്നുണ്ട്. നമ്മൾ ഇവിടെ വരുമ്പോൾ ഞാൻ 1 മാസത്തേക്ക് 2 മാസത്തേക്ക് നമ്മുടെ രജിസ്റ്റർ ചെയ്തിട്ട് അങ്ങ് കൊടുത്തു വിടും. അപ്പൊ കീലേറ്റിംഗ് ഏജൻസിന് വേണ്ടി അവർ പൈസയെ മുടക്കരുത്. നമുക്ക് ഇഷ്ടം പോലെ ഡെസ്പറാലുണ്ട്, ധാരാളമായിട്ട്. അവരുടെ വീട് എവിടെയാ? പക്ഷെ കൊല്ലത്താണോ? കൊല്ലമാണ് ഡിസ്ട്രിക്ട് എങ്കിൽ കൊല്ലം DEIC രജിസ്റ്റർ ചെയ്ത് അവിടുന്ന് നമ്മൾ അറേഞ്ച് ചെയ്യാം. അവർ കൊല്ലത്തുനിന്ന് മരുന്ന് കിട്ടും. ട്രാൻസ്ഫ്യൂഷൻ മാത്രം അവര് ഗോകുലത്ത് വന്ന് എടുക്കട്ടെ. ട്രിവാൻഡ്രം എന്നെ വന്ന് കാണാൻ പറഞ്ഞാൽ മതി. അല്ലെങ്കിൽ എന്നെ വന്ന് കാണാൻ പറഞ്ഞാൽ ഞാൻ ഇവിടുന്ന് അവർക്ക് ലിങ്ക് കൊടുക്കാം. നമ്മുടെ 2 പേഷ്യൻസിന് മരുന്ന് അവിടുന്ന് കൊടുക്കുന്നുണ്ട്. എല്ലാവർക്കും ഉള്ള എത്ര താലസീമിയ പേഷ്യൻസ് ഉണ്ടോ, all patients, all supportive treatment will be free through this comprehensive hemophilia treatment center. CHTS തന്നെയാണ് അതും ചെയ്യുന്നത്. ബിക്കോസ് ഹീമോഗ്ലോബിനോപ്പതി ഹീമോഫിലിയും കൂടെ കമ്പൈൻഡ് ആയിട്ടാണ് ഗവൺമെന്റ് പ്രോഗ്രാം. ഫണ്ടിങ് കോമൺ ആണ്. അപ്പൊ അതിന്റെ കീലേഷൻ ഒക്കെ നമ്മൾ കൊടുക്കാം. ഡെഫറാസെറോക്സ് കംപ്ലീറ്റ് കൊടുക്കും. പിന്നെ ഈവൻ ബോൺ മാരോ ട്രാൻസ്പ്ലാന്റ് ചെയ്യുന്ന പേഷ്യന്റിന് അതിന്റെ ഹെൽപ്പ് സൈക്ലോസ്പോറിൻ എന്തെങ്കിലും അത് കൊടുക്കും. പിന്നെ സ്പ്ലെനെക്ടമൈസ്ഡ് പേഷ്യന്റിന് പെൻഡിറ്റ്സ് കൊടുക്കും, ഫോളിക് ആസിഡ് കൊടുക്കും. എവറിഥിങ് വിൽ ബി ഗിവൺ, ഓൾ തിങ് വിൽ ബി സപ്പോർട്ടഡ്. പക്ഷെ ട്രാൻസ്ഫ്യൂഷൻ മാത്രം നമുക്കൊരു പ്രാക്ടിക്കൽ ഉണ്ട്. അത് ഞാൻ അവരോട് പറഞ്ഞു, യു ഗീവ് എ ലെറ്റർ ടു ദി ഗവൺമെന്റ്. ഇഫ് ഗവൺമെന്റ് ടേക്ക് എ ഡിസിഷൻ, ഞാനും ബിന്ദുവും കൊണ്ട് ഡിസൈഡ് ചെയ്തു, ഗവൺമെന്റ് പറയുകയാണെങ്കിൽ നമ്മൾ SIT-യിൽ വെച്ച് കൊടുക്കാം. പക്ഷെ നമുക്ക് ഇപ്പൊ അല്ലാതെ നമുക്കൊരു 18 വയസ്സ് കുട്ടിയെ കിടത്തിയിട്ട് ഒരു പ്രശ്നം വന്നു കഴിഞ്ഞാൽ അവിടുത്തെ മെഡിസിൻകാർ പ്രശ്നം ഉണ്ടാക്കും, ശ്രീനാഥ് പ്രശ്നം ഉണ്ടാക്കും. നമുക്ക് കുറച്ച് ബുദ്ധിമുട്ടാണ്. അതുകൊണ്ടാണ് നമ്മളിപ്പോ അഡ്മിറ്റ് ചെയ്യാത്തത്. I know, madam. These children are very upset. Parents are very upset. നമ്മൾ SAT-യിൽ അവരെ പൊന്നുപോലെ നോക്കുന്നത് പോലെ മെഡിസിനിൽ അവരെ നോക്കുന്നില്ല. നമുക്ക് എല്ലാവർക്കും അറിയാം, അതൊരു പ്രശ്നമാണ്. ഈ ട്രാൻസ്ഫോമിംഗ് കെയർ ഒരു വലിയ പ്രശ്നമാണ് ക്രോണിക് ഡിസീസസിന്.
Okay, thank you so much, Chandra. It was a very
Thank you,
good
madam.
discussion.
Thank you, madam. ഷാനവാസ്, സോറി ടൈം ഒരുപാട് എടുത്തു. ഷാനവാസ് ടൈം ഇട്ടോണ്ടിരിക്കുന്നു.
ഷാനവാസ് ഒരു കമന്റ് പറഞ്ഞ് കൺക്ലൂഡ് ചെയ്യാം.
ഷാനവാസ് ഒരു കമന്റ് പറ.
കൺക്ലൂഡ് ചെയ്യും.
Nothing to say, madam. That was very interesting and very elaborately discussed. 2 hours almost. There was some complaint regarding the time. And that's why I put it. It should not be extended beyond 9:30. It was like that, but almost 9:30 now. That's why I told like that. So it was an excellent discussion on one of the common exam topics. Invariably, there will be a short case even in DNB and also in MD. I think it was well discussed by both Dr. Sankar and Dr. Very valuable points by Dr. Roy Sankar also. Very well conducted program. Thanks to the chairperson, Dr. Sankar, Dr. Roy Sankar, Lelida madam, and the IAP Trivandrum. Thank you very much. Thank you.
The presenters also.
Presenter.
Presenter and mentor.
Yeah, right.
Swapna is there. Swapna,
tell some comment. Or Sankar can tell the comment about the presenter.
No, presenter is a good madam. Presenter is a very well presented case. Case was well നല്ല രീതിയിൽ പ്രസന്റ് ചെയ്തു. പക്ഷെ ഓൺലി തിങ് ഇസ് ഇതൊരു ക്ലാസിക്കൽ കേസ് ആയതുകൊണ്ട് DD കാര്യമായിട്ട് ഡിസ്കസ് ചെയ്യാൻ ഇതിനകത്തില്ല. ഒരു സ്ട്രൈറ്റ് ഫോർവേഡ് കേസാണ്. പക്ഷെ ഷോർട്ട് കേസ് ആയിട്ട് വെക്കും, സംശയമൊന്നുമില്ല. ഷാനവാസ് സാർ പറഞ്ഞതുപോലെ, ലളിത മാഡം പറഞ്ഞതുപോലെ ഷോർട്ട് കേസ് ആയിരിക്കും ഇത് എക്സാമിന് വെക്കുന്നത്. ഒരിക്കലും ലോങ് കേസ് ആയിട്ട് വെക്കില്ല, അതിലൊന്നുമില്ല. ഷോർട്ട് കേസ് ആയതുകൊണ്ട് നമുക്ക് ഇത്ര കേസ് പ്രസന്റ് ഡീറ്റെയിൽ ആയിട്ട് പോകേണ്ട കാര്യമില്ല. അത് പിന്നെ നമ്മൾ ഇവിടെ അങ്ങനെ പറ്റുള്ളൂ. അവിടെ ആകുമ്പോൾ ജസ്റ്റ് ഷോർട്ട് ആയിട്ട് കേസ് പ്രസന്റ് ചെയ്യുക. വിൽ ബി ഡിസ്കസ്ഡ് thoroughly regarding thalassemia and iron chelation therapy and different case of anemia, why it is not iron deficiency anemia, everything will be discussed. Okay, so well done. Presentation was good, case of selection was good, and Swapna is also commendable job.
Thank you, sir. Thank you, sir, for the excellent discussion.
Okay,
Thank you all. Thank you all.
thank you.
Thank you.
Good night.
Good night.